Good afternoon, everyone. This is the sixth in the webinar series of Oncology Insights. And me, Dr. Neeti Krishna Raizada, along with my team from Fortis Hospital, Bangalore, want to bring together a webinar on pelvic malignancies. Well, this is less spoken about, but one of the very common malignancies which exist across the globe. And our focus is on, of course, women malignancies, including cervix cancer, including endometrial cancer, and ovarian cancer. But at the same time, most common malignancy across the globe in men is prostate cancer. Although there's a lot of underreporting in our country, but we in quaternary care centers have realized even there's a lot of prostate cancer which is unreported. Similarly, in women, endometrial cancer gets unreported in our country, and therefore the actual data we have are kind of not the reflection of the true problem which we see across all oncology centers. So the focus is on one of the most common pelvic malignancy being cervix cancer, endometrial cancer, adnexal cancer with a focus on ovarian cancer, and then of course in men, prostate cancer. These will be the four important areas we'll be talking about. We'll not be talking about rectal cancer or anal cancer because they happen to be another set of malignancies. And when we talk about curable cancers, also there are cancers like testicular cancer, which happens to be a pediatric cancer and of course a cancer in young adults between 20 and 40 years. This is also cancer. If we get time in future, we'll be happy to spend more time discussing it. And these are the numbers which are a reflection of what we have in India. Almost 1,27,000 new cases are reported each year of cervix cancer, which across the globe is 6 lakh. So when you look at it, almost one third of all cancers of cervix are only reported in South Asia, especially in India. And the next important hub is Africa. Endometrial cancer, well, our reported incidence is only 20,000 cases in 2022. But this again is not the true reflection of the number of endometrial cancer which we see across India and across gynecologists, across oncologists. Often patients would have a hysterectomy, which would be because of pelvic dysfunctional uterine bleed, and we would not have done a pathology, would have missed endometrial cancer. Also, it's a cancer associated with postmenopausal bleed, with obesity, and also comorbidities. As we see, the number is significantly rising versus cervix cancer, which probably has been static or reducing, but the incidence of endometrial cancer is rising because of our becoming more, acquiring more westernized lifestyle, more limited physical activity, and of course, increase in obesity as well. Ovarian cancer is again one of the top 5 cancers in women in our country, with almost 48,000 cancers reported annually of ovarian cancer. The interesting part about ovarian cancer is that even in very advanced stage cancer, people tend to do well and they have a good survival, which may not be called as curable, but the patients survive overall in an extended period of time. It could be between 5 to 10 years with good quality of life, and and there is always a second, a third, a fourth and fifth line of therapy with not as much morbidity which we would expect. Prostate cancer reported incidence in India is only 30,000 cases every year. But again, these numbers are not true reflection of what we see in our routine practice. In urology practice, uro-oncology practice, and in medical oncology and radiation oncology practice, we see a significant number of prostate cancer across the spectrum. They are localized prostate cancer, they are locally advanced, and metastatic prostate cancer as well. Again, a cancer with very good survival. A very early stage prostate cancer may sometimes even do well with surveillance, but most often, just hormones can take care of this cancer in a very good way with well preserved quality of life. So, these are some of the common presentations of women cancer. Ovarian cancer often will be called as a silent killer. They would have very occult signs and symptoms, just bloating or sometimes dragging sensation and pelvic pain is what they have. And because of a mass in the pelvis, they sometimes can have urinary frequency or dysuria. Uterine cancer can present with abnormal vaginal bleed, often related to postmenopausal bleed, which could be either just a spotting or suddenly 1 or 2 times you would have noticed a bleed and which would have gone unattended. A vulval cancer is a cancer of the vulva which presents as pain, itching, or sometimes lump or sore in the vulva. Vaginal cancer again presents with it presents with abnormal vaginal bleed. It could also have foul-smelling discharge or sometimes just watery discharge, and there could be lump on vagina. Cervix cancer, often seen in rural India, often seen with promiscuous behavior and sometimes poor personal hygiene, is a cancer which presents again with abnormal bleed. It could be intermenstrual bleed, it could be postmenopausal bleed, and often with pelvic pain. Why do these malignancies get diagnosed late or often are ignored? Because there's lack of early symptoms. There are overlapping symptoms with just benign conditions, sometimes misdiagnosed as just pelvic inflammatory disease. There are no specific guidelines for most of these cancers other than cervix cancer. And the guidelines of cervix cancer include screening with pap smear starting from 21 years of age, and from 30 years of age doing a pap smear along with a human papilloma virus testing. Most of these cancers present quite late to us, and there is generally a poor access, a poor penetration in the peripheries to awareness of these cancers. These cancers also, some of them have very aggressive biology. These are some of the signs, and these are some of the things which we need to know and what points towards cancer prevention. One is importantly stay fit, get yourself vaccinated. We have a vaccine for cervix cancer now. It's a human papilloma virus vaccine, not just for cervix cancer, but for penile cancer, for vulval cancer, vaginal cancer, anal cancer, and also some other cancers, including head and neck cancer. You should be aware. You should be aware if you have a family history. Almost 10% of certain cancers, especially ovarian cancer, may have family history. Although other endometrial cancer also sometimes will have family history as an association. Uh, it's important to practice personal hygiene, which is an important etiology in cervix cancer. In general, have good lifestyle, including early eating healthy, staying fit at all points in time, and getting yourself checked regularly. All cases require multidisciplinary approach, and this is what we are trying to present today by saying that everybody, whether it is an oncopathologist, whether it's a radiologist, whether it's a medical oncologist, surgical oncologist, or gynae oncologist, and all of us will need to work together to make plans, individualized plans for each and every patient, so that we can maximize our results for everybody. So I will start the webinar today with announcing the winners of the last webinar, that is the fifth webinar, which was on ABC of CBC. And the first prize of this webinar goes to Dr. Ibrahim Wajid, who's an internal medicine specialist in Frasertown, Bangalore. The second prize goes to Dr. Vibha Prasanna. She is from Raksha Health and again from Bangalore. So congratulations to both of you. The first prize is 12,000 rupees of cash award, and the second prize is 8,000 rupees of cash award. Today, at the end of webinar, we will announce all the winners, including this current sixth webinar winner. So from first to sixth webinar, all winners will again be announced, and we'll be sending the certificates to each of the participants and also to all the winners. On we'll be discussing on an approach to Adnexal mass with a focus on ovarian cancer and fallopian tube cancer by Dr. Dhyaneshwaran. And the next talk is by Dr. Madhusudan on prostate cancer. So over to Sonali for the first talk.
Thank you, ma'am. Next slide. So coming to cervical cancer is the very is a common cancer seen in women around the world and in India. Coming to the incidence and the overall coming to the incidence and overall mortality of cervical cancer, it is one of the more eighth most common cancer in the incidence wise, which is about 14.1% of incidence seen in per year around the world, and with a mortality rate of 7.1%. And in India, it is 17.7% of incidence rate, with the third ranking third among throughout the world, throughout India and among both male and female sexes, and and a mortality of the same. So the majority of cases which of cervical cancer are seen in the low and middle income group countries. And next slide. So, what could be the risk factors? What were the causing for cervical cancers? Are the most common risk factor for cervical cancer is recurrent human papilloma virus infection. So, human papilloma virus, which is a sexually transmitted infection, about 70 to 80% of cervical cancer. A person has like full-term pregnancy of more than 4 to 5 pregnancies could be one of the risk factors for cervical cancer. Poor diet like obesity, smoking, poor nutrition, and poor menstrual hygiene. And all of these are a few of the risk factors which could increase your this like risk of incidence of cervical cancer. Next slide. So what is usually cervical cancer occurs at the junction of the squamocolumnar junction in the that is also called as a transformation zone, and wherein it normal epithelium can undergo dysplasia, and after it can form into CIN1, that is a cervical intraepithelial neoplasm 1, and these CIN1 can regress themselves, like spontaneous regression can occur after a few years. Otherwise, they get progress, they progress into CIN2, and further progression can be seen to CIN3. The CIN3, that is cervical intraepithelial neoplasia grade 3, or high grade squamous, also called high grade squamo as intraepithelial lesion, that is HSIL, with any cofactors like smoking, immunocompromised state, and other high risk factors, can get converted to invasive carcinoma. So the onset from this CIN1 to squamous cell carcinoma, it could be 10 to 20 years, and the CIN1, the progression of CIN1 to CIN3 is about 11%, whereas of that to invasive carcinoma is just 1%, whereas that conversion like progression of CIN3 to an invasive carcinoma is about 12% high. Next slide. So coming to the screening, so how the early detection of cervical cancer is possible when we will be able to detect carcinoma in CIN1 or CIN2 itself. So how are we supposed to do that? We can do that by just one small examination, that is a pap smear, which which has to be the next slide. So pap smear. So these pap smears have to be it is a screening module which has to be done by every women, and this like from the age of 21 up to the age of 65, which has to be done every 3 years once. So if and from the age of 30 and above, pap smear and HPV core DNA testing can be done, which has if it is being done together, then every 5 years once the screening has to be done. So the women above the age of 60, if any 3 consecutive pap smears are normal, or any 2 HPV testing consecutive HPV testing is normal, then you can stop your screening modalities. So coming to when you do a pap smear, what if you have any abnormal smear in that is or there is some asymmetrical squamous cells of undetermined significance is present, then you have to check for your HPV status. If HPV status is negative, then repeat the smear after the second smear after 1 year. And if it is again an abnormal smear, then you have to undergo a colposcopy. If it is positive, like if HPV testing is positive, then undergo a colposcopic biopsy or an endocervical curettage. And in that endocervical curettage or biopsy is negative, then repeat the pap smear after 6 months. If it is positive, then you'll have to undergo conization. So if your smear is showing any low-grade squamous intraepithelial lesion or CIN2 lesions, then depending on the age group, there is your management will vary. If the patient is 21 to 24 years old, then we have to you can repeat the cytology after 1 year. 25 to 29 years, then again, it depends on the type of HPV status. Above 30 also, HPV status has to be done. If it is positive, then you have to undergo a colposcopy. If it is negative, then again repeat the pap smear after 1 year. Next slide. So in patients who have already undergone a hysterectomy, the indications for pap smear are surgery for if any cervical cancer surgery is done post that 20 years. Post-op screening has to be continued, and if the that is a high-grade squamous intraepithelial lesion is there, HSIL, then again the screening has to be continued for the 20 years post-op. And only if it is a benign condition, the screening is not required. And other than that, HIV positive or immunocompromised women who have already had an exposure to this diethyl sorbitol in utero, or history of any cervical cancer is there, then all these women have to undergo the pap smear screening more frequently. So coming to how do we do this? We just smear is taken through the ectocervix and the endocervix both, using ectocervix using the air spatula, endocervix using the cytobrush, and we take a scraping from the cervix in the posterior fornix. And if the test is showing any CIN2 or 3, then we have to repeat the test after 2 weeks to just confirm the testing. PAP smear is approximately 94% specific, and whereas HPV testing is 96.8% sensitive and 94.1% specific. That is why we do it every 5 years once. Next slide. So other than pap smear, what other test we can do is called visual inspection with acetic acid. This is a very common test which is used in India, as it is really it is inexpensive and can be this is wherein a cervical cancer screening method where via naked eye examination of the cervix where we'll be doing it by applying acetic acid to the cervical area and to detect any pre-malignant conditions. And if any white areas appear or acetowhitening is there, then it could be there is some pre-malignant condition or a lesion present, and we have to do further testing. This one, next slide. So herein, the first one is showing a positive case in case of HSIL, whereas there is whitening is seen in the by acetowhitening is seen. And even next slide. So coming to the diagnostic workup, how are you supposed to work up workup for the patient is by first seeing the clinical history of the person. There could be symptoms, and symptoms like patient can come with symptoms like heavy or prolonged vaginal bleeding, like menorrhagia, metrorrhagia, spotting per vagina can be there. Postpartum pain or bleeding could be present. Postmenopausal bleeding is a very common symptom seen among the patients with cervical cancers. This one, any foul smelling white discharge is present, or easy fatigability, pain in the pelvic region, or low back pain can be there. Any pedal edema is there, renal failure, dysuria, hematuria, any bleed per rectum, constipation, bowel obstruction. All of these are few of the cause like clinical features of the disease, and of any, if any involvement of any neighboring structures are present, that also can be known. Next slide. So again, a pictorial representation of the same. Next slide. So after a detailed history, we'll have to do a clinical examination of the general physical examination, along with the checking of the this one inguinal nodes, and this one systemic examination, one PSPV examination, along with a per rectal examination and biomanual examination is recommended. Cystoscopy and rectal sigmoidoscopy, if required, has to be done. And imaging such as routine blood investigations, imaging such as MRI or MRI of the pelvis, abdomen pelvis, along with this chest X-ray or CT thorax is a common test which has to be done. And if we are suspecting any metastasis, then PET-CT is required. And pap smear, if no active bleeding is there, or a biopsy, a punch biopsy, or a conization colposcopy or conization has to be done to get a histopathological sample to know the type of cancer. Next. So coming to what is conization, it is a cold cone biopsy where is a large area of the tissue around the cervix is excised for examination. This, if the lesion is less than 2 centimeter, this also acts as a treatment, and whereas the whole lesion is excised and sent for examination. And otherwise, you can take a punch biopsy. That is a cervical punch biopsy has to be taken from the cervix, and it should include part of the normal tissue also, and it has to be taken from all 4 quadrants of the cervix. And radiological examination, as I told you, ultrasound is mainly used for to detect if any hydrouretronephrosis is there, or and is useful in doing brachytherapy procedures. CECT is used to, it can help in detecting the primary tumors and lateral extensions, but MRI will help in assessing the tumor and extracervical extension and is better than a CECT of the abdomen and pelvis. PET-CT is used to detect for any local recurrence and distant metastasis is present. Next slide. So coming to the staging of cervical cancer, we use a FIGO staging. And next slide. And it is classified into stage 1, stage 2, stage 3, and stage 4. Stage 1 is where it is confined to the cervix. That is, if the tumor size is less, with the depth of invasion less than 5 mm, and which is then it is stage 1A. And if it is more than 5 mm depth of invasion is there, and the size is less than 2 centimeter, or then it is 1B. And depending on the size of the tumor, it is divided again into 1B1, 1B2, and 1B3. Whereas if any invasion beyond the uterus is there, beyond the uterus but not extending into the lower vagina, then it is again it's staged as 2A, and wherein without the parametrial invasion, and if parametrium is involved, then it becomes directly 2B. Whereas in stage 3, it will involve the lower one third of the vagina, or hydronephrosis is present, or there is a non-functioning kidney, or is present, then it directly enters into the tumor, can be classified as a stage 3. And stage 3A is if the lower one third of the vagina is involved. Stage 3B is where if there is any the parametrial extension is up to the pelvic wall, or causes hydronephrosis, or there is a non-functioning kidney. 3C is involvement of any pelvic or para-aortic lymph node, whereas pelvic lymph node is 3C1, and para-aortic lymph node is 3C2, and it's a radiological staging. Whereas 4 is where there is extension beyond the true pelvis, that is, it is spread to the adjacent organs, and is 4A, that is the bladder involvement or the rectal involvement is there. And if there is a spread to any distant organs like the liver or the lung, then it goes to 4B. Next slide. So, coming to the pathological classification, the most common cervical cancer is squamous cell carcinomas. Other than that, it could be some glandular tumors like adenocarcinoma, mucinous adenocarcinoma, clear cell adenocarcinomas, adenosquamous carcinomas, adenocystic carcinoma, neuroendocrine tumors, undifferentiated carcinomas are few of the pathological types. But the others are rare. The most common is squamous, second to adenocarcinoma and adenosquamous carcinoma. Next slide. Coming to the treatment part of cervical cancer, the overview of treatment for cervical cancer is usually divided into the pre-invasive disease and the invasive disease. Whereas pre-invasive disease, again, you have the CIN 1 and 2, whereas this one is observation. Whereas if there is any persistent dysplasia, say, or high-grade HSIL is present, then there are various treatment options available. And invasive disease, you have again the surgical techniques like conization, radical trachelectomy, and hysterectomy can be done. Otherwise, you have radiation along with chemotherapy and brachytherapy are the procedures. So, next slide. Coming to the pre-invasive disease, you in CIN1 and 2, pap smears. If pap smear is showing CIN 1 or 2, it is just observation, and we repeat the pap smear again after 6 months or to 1 year time duration. And if it is persistent dysplasia or CIN3 is present, then the patient can undergo cryotherapy. The patient can undergo cryotherapy, which is having a high success, which is used in low-grade dysplasia. If it is otherwise, laser ablation can be done, which is in high-grade dysplasia patients. Cold knife conization, which can be used as a therapeutic or a diagnostic procedure, or LEAP procedures can be done, that is loop electrosurgical excision procedure, which is these procedures are having a better pregnancy outcome after the when compared to the conization method. So what is in stage 1A1 patients? This one conization is what is is done, and in conization, if we tend to know what is the depth of invasion, what is the tumor extension, the marginal status, and the LVSI. That is, and depending on the LVSI status, if it is if LVSI is not present, then the risk there is less than 1% risk of any lymph node metastasis, and metastasis is there. And if desired conization is achieved with free margins, then it is good. And if not, free margins are not achieved, then patient will have to undergo an extrafacial hysterectomy. And if LVSI is positive, then after within 6 months, the patient will have to undergo radical hysterectomy. So coming to stage 1A1 to 1B1, radical trachelectomy can be done. So what is who all can undergo this radical trachelectomy? With stage if tumor is less than 2 centimeters, LVSI negative, and age group less than 40 years, wherein the entire cervix and the adjacent parametrium is removed along with laparoscopic lymphadenectomy is done to confirm no nodal involvement. If the high or intermediate risk factors are present, the like positive margins, no, like positive margins, then EBRT has to be given after radical trachelectomy. This procedure helps in fertility preservation, and recurrence at cervicouterine junction or in adjacent parametrium is about 5% risk is there present. For stages 1A2 to 1B1, the surgical management is preferred, which is conization and can be done, or radical trachelectomy with laparoscopic lymphadenectomy if fertility preservation is preferred. Otherwise, modified radical hysterectomy plus or minus pelvic lymph node dissection if no fertility preservation is required. If medically inoperable, then we have to consider the patient for external beam RT followed by brachytherapy. Here, the tumor control with all of these methods are more than 95%. So coming to stage 1B1 to 2A, the surgical method which can be used here is again radical hysterectomy with bilateral pelvic lymph node dissection, or with or sentinel lymph node mapping can be done. And if medically inoperable, then patient will be considered for again external beam radiation followed by brachytherapy. The overall survival over here is about 70 to 90%. Surgery is usually preferred in younger age group, that is here to preserve, there is an advantage wherein to preserve the ovaries and prevents premature menopause in 50 to 60% patients. And if in postmenopausal women, radiation can be, we can directly consider the patient for radiation, or if tumor is more than 4 centimeter, then radiation is considered. So indications for adjuvant radiation or chemotherapy in such patients, it is if the post radical hysterectomy, if any positive margin is there, any parametrium involvement is there, or any lymph node involvement is there, then these such patients are usually considered for adjuvant radiation. And if any this one extranodal extension is present, then chemo also can be given together. Coming to stage 2 to stage 4A, the most common commonly used treatment modality over here is definitive chemoradiation, whereas it is external beam RT followed by brachytherapy. Like external beam RT is given along with concurrent cisplatin or carboplatin based chemotherapy, and followed by brachytherapy has to be given. External beam RT, it could be a dose of 45 gray in like the 1.8 gray per fraction for over 5 weeks, with along with cisplatin or carboplatin weekly dose, and followed by the intracavitary brachytherapy is the desired treatment option. Next. And if it is stage 4B, that is distant metastasis is already present, the main treatment options which can be which is available here are palliative chemotherapy, targeted therapy can be used, immunotherapy if PD-L1 is positive, then pembrolizumab can be used, and palliative radiation is given only for symptom relief. Next slide. So I'll be talking about HPV vaccines also, and HPV vaccines. HPV is a necessary HPV vaccine. It is a vaccine against the HPV virus. That is a it is a HPV. It is a virus-like particle, and the HPV virus being the most common cause of cervical cancer, and also HPV virus causes various other cancers like is one of the cause for various other cancers like vaginal cancer, vulvar cancer, anal cancers, penile cancers, oropharyngeal cancers, and oral cancers. So it is in cervical cancers and vaginal cancers, the most common serotype is HPV 16, 18, and this one 16, 18, 31, 33, 45, 52, and 58. And these causes more than 75% of cervical cancer and more than 50% of vaginal vulval cancer, whereas HPV 6 and 11 causes 90% of anogenital warts. So next slide. So the most common common types of vaccines which are available in India are Gardasil 9, which is a non-valent vaccine, and quadrivalent vaccines such as Gardasil and Cervavac vaccines are available. And Cervavac is a indigenous vaccine produced by Serum Institute. And the schedule for cervical cancer, these HPV vaccines are from 9 to 15 years. Boys and girls both can take these vaccines. It is a two dose schedule at 0 and 6 months, whereas women above the age of 16 up to the age of 45 can take these vaccines as 0, 1 or 2 months, and 6 months. If you're taking Gardasil 9, it is at 1 month, and if you are taking any quadrivalent vaccine, it is at a 2-month schedule. So this vaccination helps reduce risk of various cancers associated with HPV virus and genital warts. But even after completion of these immunization schedules, the individual has to continue his screening program and get a pap smear done every 3 year once. And this vaccine doesn't is not like if you're already exposed to HPV virus, this might not be of much help. It will be of use when if you're not exposed to HPV virus before taking this vaccine. Next slide. So the HPV vaccine is safe, effective, and protects against cervical cancer. This is we would recommend everybody to take this vaccine. Thank you. So I would like to ask Shweta to continue with Dr. Shweta to continue with the quiz session.
Good afternoon, everyone. Coming to the quiz first round. Before that, I'd like to thank Sonali for a very detailed presentation on cervical cancer. Coming on to the quiz instructions, each quiz will have 5 MCQs. This time, there is 4 sessions of MCQs, total 20 questions. And each session will have 5 MCQ questions, option A, B, C, D. And each question has a 30-second timer to submit your answer. In case of a tie, whoever has answered fast will get the priority. And if the quiz button is also already present in the right corner of the page, please click on that. If the next time when you submit an answer, the question vanishes off before you completing the session, please click the quiz button again. Question number 1. What is the role of E6 oncoprotein of high-risk HPV in cervical carcinogenesis? The role of E6 oncoprotein in high-risk HPV in cervical carcinogenesis. Option A, inhibit telomerase activity. Option B, degrades the tumor suppressor protein P53, promotes epithelial differentiation, or induce apoptosis. Question 2. In the 2023 FIGO staging system for cervical cancer, which of the following upgrades a tumor from stage 1B to stage 3? In 2018 FIGO staging system for cervical cancer, the following tumor will automatically upgrade from stage 1B to stage 3 if it has either a tumor more than 4 centimeter, parametrial involvement, positive pelvic lymph nodes, or vaginal involvement. Which surgical procedure is preferred for early stage cervical cancer, that is stage 1A2 to 1B1, in women who desire fertility preservation? Which surgical procedure is preferred for early stage cervical cancer in women who desire fertility preservation? A. Radical hysterectomy, B. Simple hysterectomy, C. Radical tracheotomy, and D. Pelvic exenteration. Which of the following is the standard radiotherapy approach for locally advanced cervical cancer? Which of the following is a standard radiotherapy approach for locally advanced cervical cancer? Option A, external beam radiotherapy alone. Option B, EBRT followed by brachytherapy. Option C, stereotactic body radiation therapy. And option D, whole body irradiation. Last question of this session. Which chemotherapy regimen is the standard of care for locally advanced cervical cancer? Which chemotherapy regimen is the standard of care for locally advanced cervical cancer? Option A, carboplatin with paclitaxel. Option B, cisplatin-based chemoradiotherapy. Option C, methotrexate monotherapy. And option D, bevacizumab alone. Coming on to the next presentation, I would like to invite Dr. Venkatesh Babu, consultant surgical oncologist, on a talk about endometrial cancer.
Good afternoon, everyone. I'm Dr. Venkatesh. I'm a surgical oncologist at Fortis Hospitals, Bengaluru. As our target population is not mainly oncologists, I'll be briefly covering about carcinoma endometrium today. As we all know, carcinoma endometrium, it is a type of cancer which begins in the lining of the uterus, that is endometrium. And it is one of the most common gynecological malignancies. Okay, as ma'am suggested, that the incidence of endometrial carcinoma is increasing day by day because of the current lifestyle modifications and all. And coming to the risk factors of the endometrial carcinoma, it can be divided into hormonal factors, genetic factors, and general factors. Coming to the hormonal factors, whatever things which increase the exposure of estrogen increases the risk of endometrial carcinoma. For example, obesity, estrogen therapy, and even early menarche and late menopause, all these are associated with the increased exposure to the estrogen, and that leads to the increase in the risk of endometrial carcinoma. And coming to the genetic factors, Lynch syndrome, which is also called as hereditary non-polyposis colorectal carcinoma. It is one of the important syndromes which is associated with the endometrial carcinoma. In fact, endometrial carcinoma is the second most common malignancy associated with HNPCC related syndromes. First being the colorectal carcinomas. And also, if there is a positive family history of breast and ovarian carcinoma, there is increased risk of endometrial carcinoma as well. And other factors include age, postmenopausal. That is, usually endometrial carcinoma is seen in the elderly age group. And diabetes also leads to the increase in the risk of endometrial carcinoma. This is mainly related to the its association with obesity and insulin resistance, again, all that estrogen excess, everything. And even there are some special circumstances like patients suffering from polycystic ovarian disease and breast cancer patients who are on tamoxifen therapy. All they are at increased risk of developing endometrial carcinoma. Coming to how the patients with endometrial carcinoma usually presents, any postmenopausal bleeding should alarm should suggest, like should alarm us to evaluate for endometrial carcinoma. And other symptoms being pelvic pain, difficulty in urination, and painful intercourse, all this can be present. Okay. And in the advanced cases, there can be unexplained weight loss as well. Usually, the endometrial carcinoma is mainly classified into two types. Type 1 being the endometrioid carcinoma, which is most commonly estrogen associated, and it is more common compared to the second type, which is non-endometrioid carcinoma, and it is usually not estrogen associated. And coming to the diagnosis of the endometrial carcinoma, as all carcinomas, clinical examination plays an important part in diagnosis of the endometrial carcinoma, which includes the pelvic examination and parvaginal examination. And even sometimes dilatation and curettage can be done for the tissue diagnosis. And the other things being biopsy is the confirmatory test for the endometrial carcinoma. This biopsy can be done in multiple ways. One is dilatation and curettage for tissue sampling, and the other being hysteroscopy guided biopsy. In coming to the imaging, ultrasound is usually the first investigation we do when the patient comes to us with symptoms of postmenopausal bleeding or abnormal uterine bleeding. And ultrasound will give us an idea about the endometrial thickness, any growth present, all that things. And transvaginal ultrasound will give more information compared to the transabdominal ultrasound. And the other stage for staging investigations include CT or MRI of the abdomen. CT and MRI both are good for lymph nodal metastasis, abdominal spread, etc. But MRI, especially the different forms of MRI, MRI gives us a better soft tissue delineation that will tell us about the more local staging, like depth of invasion of the myometrium, all that can be better made out on the MRI. And PET CT, yeah, it can be used in advanced cases, and usually it has around 80 to 90% sensitivity for detecting the extra pelvic spread disease. And coming to the other tests which can be used in diagnosis of endometrial carcinoma, CA-125, although it is not definitive for endometrial carcinoma, it is more relevant in carcinoma ovary, but it has been observed that elevated levels of the CA-125 is associated with the worse prognosis of the endometrial carcinoma, and it indicates a more advanced disease. And genetic testing, if there is a positive family history, as I have mentioned earlier, it is most commonly associated with HNPC syndrome. If there is a positive family history of colorectal carcinoma, endometrial carcinoma, there are different criteria to consider it as it to be a suspected familial HNPCC. And if there is a suspected familial cancer, yes, then genetic testing is also indicated. Coming to the staging of the uterine carcinoma, stage 1 disease, it is usually confined to the uterus, and stage 2 disease, if the cancer has spread to the cervix, then it is considered as a stage 2 disease. And if stage 3, if there is any spread within the pelvis, but not outside of the pelvis, basically, if the disease is spread to the ovaries or the adnexal parts or to the lymph nodes, then it is considered as a stage 3 disease. If there is any extra pelvic spread, then it is considered as a stage 4 disease. And staging of uterine carcinoma is not as simple as it is mentioned here. Yeah, recently in 2023, they have updated the FIGO staging, where it has become more complex. Grading has been incorporated, and molecular classification has been incorporated into the staging. But the treatment implications are not very well known. We are still following the stage-wise management, but its prognosis varies. Okay. When the 2023 endometrial carcinoma staging was updated, there were a lot of controversies, whether it is really helpful or the molecular staging has any any implications on the treatment, all that things. But yeah, these are the major changes which are incorporated in 2023 FIGO staging, where non-anatomical parameters like histological type, grade of the tumor, grade 1, grade 2, grade 3, lymphovascular invasion, molecular subtype, all that has been incorporated into the staging. And also the stage 3 and 4 are subdivided based on the location and size of the disease. And the main advantages of the newer staging system is that the prognosis is very well defined, but the main disadvantages is treatment implications we don't know. Like as I mentioned, molecular subtype has been incorporated into the FIGO staging. These are the 4 main types of molecular subtypes of endometrial carcinoma we see. The common being the pole E mutation and MMR deficient subtype, or P53 mutation, or no specific mutation noted. Usually among all these molecular subtypes, pole E mutated uh, subtype has a very good prognosis, and P53 mutated has very bad prognosis. And this has some treatment implications as well. Usually MMR deficient molecular subtypes are responsive to the immunotherapy. Coming to the treatment aspect of the endometrial carcinoma, the staging system which was described earlier is mainly the surgical staging system. Whenever we confirm endometrial carcinoma by an dilatation, curettage, and endometrial biopsy, or by the hysteroscopic biopsy, after CT staging or MRI, if there is no metastatic disease, then we subject the patient to the surgical staging. The important steps of the surgical staging includes total hysterectomy with bilateral salpingophorectomy, and the lymph node dissection, which includes pelvic lymph node dissection and para-aortic lymph node sampling. And if omentum is not involved, then omental sampling is also indicated. And peritoneal washings, the role of peritoneal washings is actually controversial. Previously, the positive peritoneal cytology is considered to upstage the endometrial carcinoma, but in 2009 itself, the significance of positive peritoneal histology has been positive peritoneal cytology has been debated, and the positive peritoneal cytology has been taken out. It's not an actual criteria for upstaging endometrial carcinoma staging. And nowadays, conventionally, open surgery is preferred for surgical staging, but recently, minimal invasive procedures are taking over, like laparoscopic total hysterectomy. Even the robotic assisted procedures are also considered equivalent to the open procedures. And important evidence for this is LACE trial, which is a laparoscopic approach to carcinoma of endometrium, which suggested that laparoscopy and other minimal invasive procedures are equivalent to the open procedures for surgical staging of endometrial carcinoma. And yeah, as I've mentioned, these are the steps of the surgical staging, but do all patients require total abdominal hysterectomy? Are there any conservative procedures we can try? Yes. When patients have not completed family, and if the patient desire to retain uterus, and if the disease is limited to the endometrium, yes, we can try progesterone tablets. Provera, basically, it is nothing but progestins, 10 to 20 mg per day for 10 to 14 days per month. And then again, we can repeat the endometrial biopsy after 3 to 6 months. If there is persistent hyperplasia, then we can try using higher doses of progestins. And even after that, if there is persistent hyperplasia, then hysterectomy is suggested. And if the patient has completed her family, then yeah, then we can consider patient for the hysterectomy. And does all patients require pelvic lymph node dissection? No. Very early stage endometrial carcinomas usually doesn't require pelvic lymph node dissection or the proper surgical staging. The things which indicate like when do we have to complete the surgical staging is grade 3 tumors or grade 2 tumors which are more than 2 centimeters in size, and some high risk histologies like clear cell carcinomas, serous carcinomas. Usually serous carcinomas are have very poor prognosis compared to the other serous and clear cell carcinomas have poor prognosis compared to the endometrial variant. And if the patient is suspected to have more than 50% endometrial invasion, then yes. And if there is if there is extension of the cervix, then yes, patients can be considered for the pelvic proper surgical staging. And again, one more controversial topic is para-aortic lymph node dissection. Usually, para-aortic lymph node dissection significantly increases the operating time, blood loss, as well as complications in the post-operative period. And we also know that if the pelvic nodes are positive, then there is 50% possibility that para-aortic nodes will be positive. And if the pelvic nodes are negative, then there is very less probability of para-aortic nodes being positive. So it will be a good strategy to palpate para-aortic nodes intraoperatively, and if any enlarged nodes are present, then sampling of enlarged para-aortic nodes is sufficient. Coming to the adjuvant therapy, that is after surgical staging of endometrial carcinomas, if it is stage 1A, grade 1 and grade 2, that is early stage carcinoma and low risk carcinomas, then usually no further treatment is required. And if there is if the disease has spread to the cervix, or if it is a higher stage 1, that is stage 1B, then there is increased risk of vault recurrence. So in such patients, vault brachytherapy can be given. And if any node positive disease will require other forms of the radiation, like it requires irradiation to the pelvic nodes, para-aortic nodes, all that things, along with the chemotherapy. And if there is an extra pelvic spread, then yes, definitely chemotherapy along with the whole abdominal radiation can be given. These are the possible options for the adjuvant therapy, that is observation, walled brachytherapy, external pelvic radiation, extended field radiation, and whole abdominal radiation. Observation, as I have mentioned earlier, stage 1A, grade 1, 2 tumors usually have an excellent prognosis, and they usually doesn't require any adjuvant treatment. And walled brachytherapy, that's for stage 1B or stage 2 cancers where there is disease spread to the cervix, then vault brachytherapy can be given. It reduces the risk of vault recurrence. And coming to the EBRT, it is nothing but an external beam radiotherapy. Here, instead of the external source of radiation is used to irradiate the body structures. And whenever patients have a little higher stage disease, that is positive pelvic nodes and positive para-aortic nodes, external beam radiation therapy can be used. And the one good thing about external beam radiotherapy is it gives good local control as well. That is, vault recurrences are similar compared to the brachytherapy. That is, it is as effective as brachytherapy for the local control, and it is effective in controlling the regional, that is pelvic lymph node disease and para-aortic lymph node disease as well. And the other forms of adjuvant treatment includes extended field radiation therapy. This is usually considered in the patients with the positive para-aortic lymph node disease. And usually the toxicity with the extended field external radiation will be higher, considering like there will be radiation to the bowel and other intra-abdominal structures. But with the recent advancements like intensity modulated radiation therapy, the side effects are under control only. Coming to the whole abdominal radiation, when we have completely excised the extra-abdominal disease like peritoneal metastasis or mental disease, Adnexal disease, etc., so whole abdominal radiation can be considered. And even some high-risk histologies which have bad prognosis like serous carcinoma, clear cell carcinomas can be considered for whole abdominal radiation when they have positive peritoneal cytology. Coming to the third important component of the treatment, that is chemotherapy. Usually the role of chemotherapy in the early stages, that is stage 1 and 2, it is limited, especially in the stage 1, grade 1, 2 tumors, it is limited. But whenever there is a node positive disease, yes, chemotherapy needs to be added. That is, any stage 3 and above, which is node positive disease, chemotherapy should be incorporated with the radiation in adjuvant setting. And other high risk cytologies like serous carcinoma or clear cell carcinomas, there is definitely an improvement in the survival, failure-free survival or the recurrence rates when there is addition of chemotherapy. And as you all know, all stage 4 disease will require chemotherapy. And the important drugs which are used in the chemotherapy of carcinoma endometrium are similar to that of the ovary, that is platinum and taxane-based chemotherapies. And nowadays, as I've mentioned earlier, there are certain we are classifying endometrial carcinoma based on the molecular subtyping as well. And usually, MMR deficient carcinomas are sensitive to immunotherapy as well, and which is used in the recurrent or the metastatic setting usually. And uh, coming to the other forms of treatment which are used in the treatment of endometrial carcinoma, as I mentioned earlier, hormonal therapy can be used in the form of progestins if the patient is willing to preserve the uterus and if they have not completed their family. And the main etiology for endometrial carcinoma, as I mentioned, is estrogen excess. So some of the anti-estrogenic medications estrogenic medications can be used in the treatment of endometrial carcinoma. Like in postmenopausal women, the main source of estrogen is peripheral conversion. That is, so aromatase inhibitors like anastrozole, letrozole can be used in the treatment of endometrial carcinoma. And coming to the screening what are the screening? General screening is usually not recommended in case of endometrial carcinoma, but patients who are at high risk of developing carcinoma endometrium, that is like patients with known HNPCC risk, they can be subjected to periodic pelvic examination and transvaginal ultrasound starting from 35 years of age. And in certain special conditions, like if the patients are on tamoxifen therapy, suppose breast cancer patients who are taking tamoxifen as a part of hormonal therapy, there is increased risk of endometrial carcinoma. They also need screening screening with the transvaginal ultrasonography for endometrial thickness. And any endometrial thickness of more than 4 mm in the postmenopausal woman should raise the suspicion of endometrial carcinoma. And maintaining a good, healthy lifestyle and healthy diet and managing the hormonal profile will reduce the risk of endometrial carcinoma. That's it. Okay. Thank you. And I'll hand over to Dr. Shweta for second round of quiz.
Thank you, sir, for a detailed presentation about endometrial cancer. Coming on to the quiz second session, I would like the participants to click on the quiz button on the right corner of the page. Question number 1. In molecular classification of endometrial cancer, identified by the Cancer Genome Atlas, which has the best prognosis? In molecular classification of endometrial cancer, identified by the Cancer Genome Atlas, which has the best prognosis? A. Pole ultra mutated. B. Microsatellite instability high. C. P53 abnormal, that is P53 mutated. And D. Low number endometrioid like. Question 2. In MRA assessment of endometrial cancer, which sequence is most useful for assessing myometrial invasion? I repeat, in MRA assessment of endometrial cancer, which sequence is most useful for assessing the myometrial invasion? Option A, T1 weighted imaging. Option B, diffusion weighted imaging. Option C, dynamic contrast enhanced MRI. And option D, proton density MRI. Question 3. Which histological subtype of endometrial cancer has the highest risk of nodal metastasis even in early stage disease? Which histological subtype of endometrial cancer has the highest risk of nodal metastasis even in early stage disease? Option A, endometrioid carcinoma. B, clear cell carcinoma. C, serous carcinoma. D, mucinous carcinoma. Question 4. Which adjuvant therapy is recommended for FIGO stage 3 endometrial cancer with positive pelvic lymph nodes? The adjuvant therapy recommended for FIGO stage 3 endometrial cancer with positive pelvic lymph node. Option A, radiation therapy alone. B, chemotherapy alone. C, hormonal therapy. D, combined chemoradiation. Last question of the session. Which drug is commonly used as an hormonal therapy for advanced endometrial cancer? Which following drug is commonly used as an hormonal therapy for advanced endometrial cancer? Option A, tamoxifen. Option B, letrozole. Option C, methotrexate. And option D, cisplatin. Coming on to the third session of this last webinar, I would like to invite Dr. Tyaneshwaran, consultant medical oncologist, for a detailed presentation on approach to adnexal mass.
Good afternoon, everyone. Thank you, Sweta, for introduction. So I'm going to talk about approach to adnexal mass. So what is adnexal mass? It's a mass originating from the ovaries, fallopian tube, and structures around the organs. It's called adnexal mass. So it's common in all age groups. So it can be either benign or malignant or physiological changes also. So usually detected, it's asymptomatic. It's usually detected during physical examination or pelvic imaging like ultrasound abdomen or CT abdomen for some other reason if you are undergoing. So less commonly, an adnexal mass may present with symptoms of acute or intermittent pain. So what are the differential diagnoses? It's from ovary or tube or extra ovarian or extra tubal. So it can be benign or malignant. So benign, it is in ovary, functional or corpus luteal cyst, luteum of pregnancy, thecal luteal cyst, and polycystic ovaries and cystadenoma, benign ovarian germ cell tumors, and benign sex cord tumors. In tubal, it is ectopic pregnancy, and extra ovarian, it is a para-ovarian cyst, paratubular cyst. So malignant in ovary, it is epithelial carcinoma and germ cell tumor, malignant sex cord tumors. And tubal, it is epithelial carcinoma, and again it's serial tubular intraepithelial neoplasia. So extra ovary, it is metastatic endometrial carcinoma and cystadenocarcinoma. So what are the non-gynecological causes like benign and malignant? So benign is constipation, appendicular abscess, diverticular abscess, pelvic abscess, bladder diverticulum, urethral diverticulum, pelvic kidney, peritoneal cyst, nerve sheath tumor. In malignant, it's appendicular appendiceal neoplasm, bowel neoplasm, and metastasis from colon, lymphoma, and breast, and retroperitoneal sarcoma. So what are the symptoms we can expect? So pelvic pain or pressure symptoms. So it's the most common symptoms. It can be unilateral and it can be variable intensity. So sometimes patient present with the abdominal fullness or pressure, and gastrointestinal symptoms like nausea, vomiting, constipation, and bloating sensation, and urine symptoms like difficulty in passing urine or polyuria, dysmenorrhea, fever, abnormal uterine bleeding. So what are the investigations we can do for adnexal mass? So basic investigation is ultrasound. It's a transvaginal ultrasound. It's a single most effective investigation for ovarian masses, and followed by computer CT scan, MRI. So PET scan usually not recommended, but once the diagnosis is established with ultrasound, transvaginal ultrasound or biopsy to rule out metastasis, we can do PET scan. So the big ovarian and extra ovarian masses should be evaluated by using transvaginal and transabdominal ultrasound sonography approaches. So there are multiple it is benign or malignant. One is iota scoring system, which include character of the ovarian size, surface, and papillary projection, and cyst wall and vascularization. So based on that, we can classify adnexal tumor into ovary benign and malignant. So benign cyst we can suspect when the cyst is uniocular cyst and size is less than centimeter, thickness is less than 7 millimeter, and presence of acoustic shadows, no detectable Doppler signals. In malignant, one is irregular solid tumor and irregular multilocular solid cystic tumor, more than 10 centimeter diameter, more than 4 papillary structures, and presence of ascites and high Doppler signaling. Color score is 4. So tumor markers. The tumor markers are very, very important, particularly in ovarian cancer and tubal cancer and peritoneal cancer. So CA125 is a common tumor marker we use to analyze pelvic adnexal masses. The sensitivity of the tumor marker is 61 to 90%. Specificity is 70 to 93%. So other tumor markers like human epidermis for protein 4, and LDH, alpha fetoprotein, and beta HCG. So it's a common tumor marker used to analyze the adnexal masses. So what are the causes for CA125 rising? So CA125 can be raised in benign and malignant conditions. So malignant conditions like endometrial cancer and epithelial ovarian cancer, peritoneal cancer, and fallopian tube cancer. So benign tumors like endometriosis, ovarian cyst, Meg syndrome, menstruation, ovarian hyperstimulation, pelvic inflammatory disease, pregnancy, and leiomyomas of the uterus. So non-gynecological conditions like ascites, pleural effusion, pericardial effusion, pancreatitis, cardiomyopathy, cystic fibrosis, cirrhosis of liver, colitis, appendicular abscess. So these are all the markers commonly we used to do to differentiate various type of germ cell tumor and the ovary. So how to classify adnexal mass into high risk and low risk? So high risk features include age more than 50, presence of family history, particularly breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, and family history positive of BRCA mutations. And symptoms are persistent, multiple symptoms. Chronic symptoms will be there in high risk. In low risk, no symptoms will be there, and no family history. Age will be less than 50. So in physical examination, large fixed irregular mass, evidence of ascites or metastasis in high risk. In low risk, not much features compared to high risk. So tumor markers are elevated in high risk, compared to high risk, low risk less elevated or nil. So ultrasound finding we discussed already, more than 10 centimeter thick multilocular septation, increased or mixed echogenicity, and solid component and papillary growth present in high risk. In low risk, less than 10 centimeter, thickness is more 2 millimeter, uniocular, homogeneous, hypoechoic, absent papillary growth. So multimodal test. So multimodal test means which include tumor markers, ultrasound finding. This included. So in RMI, it's called risk of malignancy index, which include ultrasound score, menopausal status, and CA125. Cutoff is 200. If anything above 200, it is very significant. The sensitivity is 85% and specificity is 97%. So other scoring system, Roma scoring system, it's risk of ovarian malignancy algorithm, which includes CA125, HE4, and menopausal status. So CA125 is useful in differentiating adnexal mass with elevated CA125 and suggestive of endometriosis. So ORATS ultrasound assessment. So here 5 scorings are there. So ORATS 1 means normal over. It includes follicles, either simple cyst or corpus lutea, less than 3 centimeter. So ORATS 2, it's almost benign. ORATS 3, it is a risk of malignancy is 1 to 10%, 1 to less than 10%. ORATS 4, the risk of malignancy is 10 to less than 50%. ORATS 5, risk of malignancy more than or equal to 50%. So premenopausal woman with adnexal mass, how to approach? So as we discussed, we have to do ultrasound and we have to classify based on the ORAT score. If ORAT scores are 5 or suggestive of metastatic disease, particularly ascites, peritoneal mass, and enlarged multiple lymph nodes, so you can go ahead with the surgical procedure to take out biopsy, or you can go ahead with the biopsy followed by neoadjuvant therapy and followed by surgery and followed by adjuvant therapy. If patient does not meet the above criteria, but patient still having acute pain and concern for suspected torsion, again we can proceed with the surgical method. If there is no acute pain, there is intermediate mass in imaging, so we have to look for tumor markers like CA125. If CA125 is above 200, we can strong suspicion of malignant surgical management. If it is not there, active surveillance is indicated. If low risk mass, the ORAT score also 3, again active surveillance is required. In postmenopausal woman, adnexal mass, so high risk mass on imaging like ORATS 5 and evidence of metastatic disease like peritoneal disease, peritoneal mass, ascites, and enlarged lymph nodes, and CA125 raised and mass more than 10 centimeter. So proceed with surgical management of biopsy. So if it is not there, if intermediate, See, again, you have to check for tumor markers and other risk factors. If it is risk factors present, proceed with surgical, otherwise active surveillance. If it is low tumor mass and ORADS is 3, again active surveillance is indicated. So when to refer to oncologist? So yeah, there are premenopausal and postmenopausal. Premenopausal, elevated CA125 level and ascites and evidence of abdominal or distal metastasis, we can refer by patient to oncologist. In postmenopausal, elevated CA125 level, presence of ascites or nodular or fixed pelvic mass, and evidence of distal metastasis or abdominal metastasis. So right time, if a patient present with these above mentioned features, can be referred to oncologist. Thank you very much.
Thank you, sir, for presentation about how to go about the adnexal masses. Coming on to the next quiz session. Quiz number 3. I'd like the participants to click on the quiz option in the right corner of the page. Question number 1 of this session. Which of the following benign conditions can cause an elevated CA125 level? I repeat, which of the following benign conditions can cause an elevated CA125 level? Option A, endometriosis. Option B, pelvic inflammatory disease. Option C, uterine fibroids. Option D, all the above. Question 2. Which of the following is a malignant M feature in the iota simple rules? Which of the following is a malignant feature in the iota simple rules? Option A, presence of more than 4 papillary projections. Option B, unilocular cyst with thin wall. Option C, acoustic shadowing. And option D, no blood flow on Doppler. Question 3. Postmenopausal women with an adnexal mass has a CA125 level of 80 units per milliliter. Which is the most appropriate next step? Option A, repeat CA125 in 3 months. Option B, immediate laparoscopic cystectomy. Option C, imaging with transvaginal ultrasound. And option D, start neoadjuvant chemotherapy. Question 4. Which of the following improves overall survival in advanced stage ovarian cancer? Which of the following improves overall survival in advanced stage ovarian cancer? Option A, primary cytoreductive surgery achieving R0 resection. B, neoadjuvant chemotherapy without surgery. Option C, oophorectomy alone. And option B, omental biopsy only. Last question of this session. Which is the standard first-line chemotherapy regimen for advanced epithelial ovarian cancer? What is the standard first-line chemotherapy regimen for advanced epithelial ovarian cancer? Option A, carboplatin and paclitaxel. Option B, cisplatin, doxorubicin. Option C, bevacizumab, cyclophosphamide. And option D, gemcitabine and topotecan. Coming on to the last presentation for this session, I would like to invite Dr. Madhusudan, Senior Consultant Radiation Oncologist, for a presentation on the same.
Hello, hi, good evening, everyone. Today we are going to discuss about prostate cancer. Prostate cancer is one of the common cancers in India in men. The prostate cancer is a type of cancer that occurs in the prostate, a small walnut-shaped gland in men that produces the seminal fluid. It is one of the most common types of cancer in men, particularly in the over 50 years of old. What are all the risk factors for prostate cancers? risk factor for prostate cancer is increasing age. The most common is with increasing age, especially after 45 to 50 years of age. That's one of the commonest factors. The other thing is a family history of prostate cancer or family history of pancreatic cancers. About 3 to 4% of prostate cancers can be hereditary. Then the race. The Africans or Africo-Americans have the highest risk of getting prostate cancers. The next is the diet, especially if we are going to the one who is eating red meat and high amount of saturated fats may have the high risk of getting prostate cancers. So what are all the symptoms of prostate cancers? Okay. So I have shown in the figure here, the initial symptoms of prostate cancers are related to compression of the urethra. Because urethra passes through the prostate, and before we develop the metastatic symptoms, we develop symptoms related to the compression of the urethra. It is very difficult to differentiate between the symptoms related to benign prostatic hypertrophy or the malignancy, because both compresses the urethra and both can cause symptoms. In early stages like urgency, frequency urination, like other benign urinary symptoms, it will also present. Okay. And then sometimes blood in the urine can be there. Some of the patients, especially about 20 to 30% of the patients, they do present with symptoms related to the bone, especially back pains, spinal pains, which is quite common. How do we diagnose prostate cancer? I can say in a simple term that is prostate cancer is a cancer with just one simple blood test. We can screen, we can diagnose the prostate cancers. Compared to other tumor markers, we do a lot of tumor markers in oncology. Compared to other tumor markers, prostate cancer has got more sensitivity and specificity in detecting prostate cancers. So PSA test is a very simple test. With just simple blood test, in just 3 to 4 hours, we can get the results. The other thing is distal rectal examination. Like we do a distal examination. If you find any abnormal or hard growth, do a biopsy. And then the MRI and the PET CT scan you can do. There is a new concept called PET MRI, where we combine the PSMA PET scan and MRI for the more early detection of prostate cancer, and also to select which part of the prostate to do the biopsy. Is there any screening guideline for prostate cancer? American Society of Guidelines says that start the screening at the age of 50 for average risk for a general public. Okay. Start screening at 45 for men at high risk. Who are all those with high risk? One is the Africans or Africo-Americans, or someone with a first degree relative diagnosed to have a prostate cancers. Start at the age of 40. Somebody with multiple relatives diagnosed to have a cancers, prostate cancer, or somebody who has been in the family diagnosed less than 40 years is an indication to start screening at 40. In general, what we do in oncology is, if somebody, the first degree or a second degree relatives or multiple relatives has been diagnosed with cancers, we just start the screening 1 decade earlier than what the earliest age of presentation. So this is a flow chart for somebody if we come across an elevated PSA. How to proceed when we come across someone with elevated PSA. First thing is, if you notice that there is an elevated PSA, then do multiparametric MRI. Okay. So go through the reports. If biopsy is required, if there is suspicious, based on the PIRADS category, actually, we can PIRAD 1, 2, 3, 4, 5 are there actually. Okay. Based on the PIRADS category, higher risk means do the biopsy. If PIRADS category says it's a benign lesion, no need to do the biopsy. Okay. If it's a local, then if biopsy comes positive, do the staging. called PSMA PET scan, localized disease versus metastatic disease, and then we do the treatment based on that. So treatment of prostate cancer depends on the stage with which diagnose. Stage 1 is completely localized to the stage 1 and 2 are both are localized to the prostate. Whereas in stage 1, generally the option of stage active surveillance is suggested. Okay. Whereas stage 2, the active surveillance versus treatment would be suggested. Stage 3, generally the prostate has breached the capsule or involved the seminal vesicles. In stage 4, either a local spread or spread to the different organs will be. It's the overview of treatment options in prostate cancer. Okay. If it is a localized disease, surgery, radiation therapy. Radiation therapy include both external radiation therapy, brachytherapy, stereotactic treatment include. Okay. And then if there is a biochemical relapse following either one of the treatment, other treatment can be taken as a solvase treatment. Then castrate sensitive, there's another mode called castration sensitive. If it is a metastatic prostate cancer, we divide into castrate sensitive or the castrate resistant prostate cancers. Those with castrate sensitive prostate cancer, generally we go with the new generation anti-androgen therapies like enzalutamide, apalutamide, or abiraterone. Especially in a metastatic castrate-resistant prostate cancers, we go with the chemotherapy options. If somebody has been diagnosed with a localized prostate cancer, before we proceed with the treatment, we classify into 4 groups, so 5 groups. Among them, there mainly we characterize into low risk, intermediate risk, and high risk. Okay. The treatment will depend upon whether it is a low risk, intermediate risk, or high risk. For high risk cases, always treatment is required. Okay. It includes a local therapy plus androgen deprivation therapy. For intermediate cases, favorable intermediate cases, there are 2 groups will be there: favorable intermediate and unfavorable intermediate cases. Okay. In unfavorable intermediate cases, where more than 50% of the core biopsy is positive, treatment is always suggested. In other categories like very low unfavorable risk factors, depending upon the patient's treatment suggestions, like either you can go for observation or you can go for local treatment, or we have to discuss with the patient about the available treatment options, whether the intention of the patient is to take the treatment or not. We decide and we go proceed. Among the local treatment, there are mainly 3 more treatments: external beam radiation therapy, brachytherapy, and radical prostatectomy. The other one is like no treatment, the active surveillance. Okay. These are the 4 main modalities of treatment. Active surveillance is no treatment, you just follow the patient. In that one, already discussed, for very low risk and low risk, in sometimes of favorable intermediate risk, we can have an active surveillance without the treatment actually. Each modality has got its own advantages and disadvantages. When we go with the radiation therapy, there is a low risk of urinary incontinence, but there is a high risk of erectile dysfunction. The erectile dysfunction is a common problem with all the treatment modalities, whether it's a surgery or whether it is a radical prostatectomy. The main disadvantages with the radical prostatectomy is urinary incontinence. If you take the control rates with the external beam radiation therapy, brachytherapy, and prostatectomy, all have equal control rates, including the stereotactic treatment. The treatment landscape for a metastatic prostate cancers. So what we discussed was a localized treatment cancer, where I told you about the surgical part. I told about the radiation therapy part, and I also told about active surveillance. In a high-risk cases, along with the local therapy, patient also requires androgen deprivation therapy. The androgen deprivation therapy varies from 2 to 3 years in high-risk cases and about 6 months in intermediate risk cases. In the metastatic prostate cancer, which is quite commonly we see the metastatic prostate cancer, the landscape of treatment depends on like what treatment we are given, what is the intention of the patient, the survival of the patient, the fitness of the patient. So many other parameters are involved. So if you do not look into that and just if you look at what treatment available options, we generally characterize them into metastatic hormone-sensitive prostate cancer, metastatic then metastatic castrate-resistant prostate cancers, and then we tell them that whether the patient has received the first-line treatment, should we go for the chemotherapy on. Initially, we would like to start with the oral second-generation androgen deprivation therapies like apalutamide, enzalutamide, or the abiraterone drugs actually. And chemotherapy is also a first line for treatment for both hormone-sensitive and castrate-resistant prostate cancers. The next comes for already we have exposed either one of them. You can, if patient has been given chemotherapy, go for the second-generation androgen blockers, or if androgen blockers are given nowadays, we commonly give second-generation androgen blockers, which will be followed by the chemotherapy. Then we go for abiraterone or enzalutamide. There are some special cases like where or immunotherapy we also give. There are special cases where immunotherapy can be given like MSIH, also called deficient MMRs or MSI high tumors. Okay. There is a role of nuclear medicine therapy called lutetium PSMA therapy or alpha therapy, also which we say that is in a metastatic settings. Okay. If there are very few cases where we can also see there is some hereditary genes which are positive. In such cases, we can give PARP inhibitors like olaparib and rucaparib. If there is any major small cell component is there, we go for a platinum-based chemotherapy. In the nuclear medicine therapy, there are two options, that lutetium PSMA therapy or alpha therapy. And the other one is the bone seeker, something called radium-223 can also be given. They all improve the survival. And there is one more kind of immunotherapy called sipulicity, where we use the dendritic cells to act against the cancer cells actually, which is specifically for the, it's a kind of, I can say it's a kind of CAR T cell therapy we use specifically for the prostate cancers. Thank you, everyone.
Thank you, sir, for a very detailed presentation on management of prostate cancer. Coming on to the last quiz session. Participants, please click on the quiz button on the right corner of the page. Question number 1. Which of the following genetic mutation is commonly associated with hereditary prostate cancer? Which of the following genetic mutations is most commonly associated with hereditary prostate cancer? Option A, BRCA2, option B, APC, option C, TP53, and option D, KRAS. Question number 2. Which of the following best defines high-risk localized prostate cancer? Which of the following best defines high-risk localized prostate cancer? Option A, PSA less than 10, Gleason score less than or equal to 6. Option B, PSA 10 to 20, Gleason 7, T2B. Option C, PSA more than 20, Gleason more than or equal to 8, T3. Or option D, any PSA level with normal digital rectal examination. Question 3. Which is the most common side effects of androgen deprivation therapy? Which is the most common side effects of androgen deprivation therapy? Option A, liver toxicity. Option B, osteoporosis. Option C, peripheral neuropathy. And option D, pulmonary fibrosis. Question number 4. Which of the following PSA is considered the traditional cutoff for prostate cancer suspicion? Which of the following PSA values is considered the traditional cutoff for prostate cancer suspicion? Option A, 1 nanogram per milliliter. Option B, 2.5 nanogram per milliliter. Option C, 4 nanogram per milliliter. And option D, 10 nanogram per milliliter. Question number 5. Which of the following is the standard surgical treatment for localized prostate cancer? Which of the following is a standardized surgical treatment for localized prostate cancer? Option A, transurethral resection of the prostate. Option B, open radical cystoprostatectomy. Option C, radical prostatectomy. And option D, simple prostatectomy. The winners of this quiz session will be announced after the quiz discussion at the end of this program. Coming on to the answers for the quiz, the role of E6 oncoprotein of the high-risk HPV in cervical carcinogenesis. It degrades the tumor suppressor protein 53. Because of this, apoptosis will be inhibited and cell proliferation proliferation happens. In FIGO staging for cervical cancer, which of the following upgrades a tumor from a stage 1B to 3? It is positive pelvic nodes. These are the pelvic lymph node drainage of a cervical cancer. The main node is paracervical nodes. From there, it is the internal, external iliac nodes, common iliac nodes, obturator nodes, presacral nodes, and little upstage, it is para-aortic nodes. Question 3, which is a surgical procedure preferred for early stage cervical cancer in women who decide fertility preservation? It's radical trachelectomy, which is the removal of the lower margin of the cervix with sparing of the uterus. And later suturing will be done for continuation of pregnancy. Which of the following is a standard radical approach for locally advanced cervical cancer? It is EBRT followed by brachytherapy for all cervical cancer stage 2B onwards and some stage 1, 2A. It is the definitive CTRT followed by brachytherapy is the choice of treatment. When highest stage 4A and 4B, there is an option of neoadjuvant or adjuvant chemotherapy along with the above procedures. Which chemotherapy regimen is the standard for locally advanced cervical cancer? Cisplatin-based chemoradiotherapy, because cisplatin in a small dose, 40 milligram per meter square, acts as a radiosensitizer and enhances the effect of radiation, and it improves the survival, reduces the risk of recurrence and distant metastasis, and also it is well tolerated in patients who are not able to tolerate cisplatin, like nephrotoxic patient, already compromised renal functions, and all year audiometry showing they have a vast neurovascular deficiency, sensorinal nerve hearing loss, then for them carboplatin will be preserved. In molecular classification, cancer genome atlas, best prognosis comes to pole mutation. As you can see, prognostic risk groups, recently endometrial update, they have incorporated the molecular study of the endometrial cancer to stage and risk stratify the patient. In that, low risk will be any pol hypermutated, ultra mutated patients will have a low risk and stage 1 to A, 1 to B. 1 and 2A. Intermediate risk and high risk. In high risk, any P53 abnormality will come under high risk, which needs to be treated aggressively, and also any non-endometrial endometrial cancers will also be coming under a high risk group. In MRI assessment of endometrial cancer, it is dynamic enhanced contrast enhancement MRI picture, which will use for assessing the myometrial invasion. As you can see in the picture, mainly it is T2 weighted imaging, which will differentiate the myometrial, which will give us a clear picture of the myometrial thickening, followed by it is a contrast enhanced, diffusion contrast enhanced imaging. Which histological type has the highest risk of nodal metastasis? It is serous. Even in the early stage, serous carcinoma will have a 40 to 60% of nodal, and it is highly aggressive, and also high chance of peritoneal spread is there. Question number 4. Which adjuvant therapy is recommended for FIGOS 3 endometrial cancer with positive pelvic lymph node? It is combined chemoradiotherapy. Which drug is commonly used in hormonal therapy for advanced endometrial cancer? Is letrozole. As you can see, letrozole's primary action will will have an effect on the ovarians, and also GnRH continuously release, which will suppress the ovulation cycle, and also in peripherally control the release of estrogen, which has a role in the low risk serous adenocarcinomas. Benign condition causing elevated CA125 is all the above conditions. These are some conditions where CA125 might be elevated, like endometriosis, any benign ovarian pathologies, fibroids, pelvic inflammatory disease, and non-gynecologically any peritoneal or parenchymal coverage involved, like irritations like cirrhosis, ascites, pancreatitis, interstitial lung disease, pericardial disease, and also in certain non-ovarian cancers like breast cancers, lung cancers, endometrial cancers, these will be elevated. Which is the malignant feature in the aorta simple root is more than 4 papillary projections. Malignant role is it should be either in irregular solid tumor, presence of ascites, at least 4 papillary symptoms, structures, and irregular multilocular solid tumor with large diameter more than 100 millimeter and high Doppler blood flow, color score 4. A postmenopausal woman in Adnexal mass has a CA125 level of 80 units per ml. What is appropriate next step will be an imaging with a transvaginal ultrasound. It mainly involved for aiding us in differentiating the endometrial and also ovarian cancers, and also in the early detection, characterization of the tumor, and also monitoring of post-treatment surveillance. Following improves the overall survival in advanced stage ovarian cancer is R0 resection. As you can see, if there is R0 resection, the survival 5-year overall survival rate is 50 to 60% in case of an ovarian cancer. As the residual tumor volume increases, the percentage of survival decreases. The first line, the standard chemotherapy regimen for advanced epithelial ovarian cancer is carboplatin and paclitaxel. Ovarian cancers are highly platinum sensitivity, and carboplatin will have a cytotoxic effect by inducing a cross-linking and apoptosis. And this paclitaxel synergy, which is mainly due to its action on a microtubule stabilizing, so that this carboplatin can act and increases the tumor cell death. The combination of this therapy has shown a high response rate of 70 to 80% in newly diagnosed cases. Genetic mutation most commonly associated with hereditary prostate cancer is BRCA2. As you can see, majority of the prostate cancer is not genetically disposed, but certain mutations are already to look out for and keep a watch on, like BRCA2 mutation, PALB2, BRCA1, CDK12, and ATM mutation. Which of the following defines high-risk localized prostate? Is PSA value more than 20, Gleason score more than 8, and T3. As you can see, very high risk, the recurrence rate of the the 5-year biochemical recurrence-free survival reduces compared to the low risk, and survival also rests. So vigorous treatment will be there, and risk of metastasis in this high-risk individuals crosses more than 30 to 50%. Which is the most common side effect of androgen deprivation therapy? It is osteoporosis. As you can see, androgen therapy will act on the androgen receptor aromatase, which will cause certain toxicities and decrease muscle mark. Osteoporosis and fracture is the most common chronic toxicity seen in these patients. PSA value considered as a traditional cutoff for prostate cancer suspicion is 4 nanogram per ml. PSA value changes occur in each age group, like less than 40, upper limit is 2. If it is 60 to 69, it is 4.5. But any time more than 4 should always be further evaluated with a biopsy. Which of the following is a standard surgical treatment for localized prostate cancer? Is radical prostatectomy, which is the removal of the prostate along with the tumor in situ and the gland and neck of the bladder. After the procedure, reconstruction of the bladder neck will be done. I would like to invite, before that, I would like to invite Dr. Sharath to present the vote of thanks and also display the webinar winners, quiz winners. They will present some. Yes.
Good evening, everyone. Myself, Dr. Sarath Chandra, surgical oncologist. So it was a very enlightening scientific session today regarding the pelvic malignancies. Here we should understand that pelvic cancers, pelvic malignancies are highly curable in their early stages. So it was a very informative scientific session today. I thank all the participants for actively participating and showing the interest. So I would like to announce the winners for the quiz that is being conducted. Can I mention?
Yes, sir. Webinar.
So for the quiz that was conducted during the webinar held on 11th February 2025, the first prize goes to Dr. Raksha KV. So she has won the quiz conducted during the webinar on 11th February. Next.
Hi, I'm Dr. Sonali. So, coming to the first webinar, number one, which was conducted on 11th February 2025, there were two doctors who have won the first prize. One is Dr. Raksha and Dr. Raksha KB from ESIC Medical College, ESIC MC Hospital, Bangalore. And she is sharing a prize with Dr. Shruti SS, who's also from ESICMC Hospitals, Bangalore. And the second prize is going to Dr. Aziza Fatima, who is working at Government Unani Medical College and Hospital, Bengaluru. And the coming to our winners of the second webinar, which was conducted on 14th February with the topic Pediatric Hematology and Oncology in Office Practice. In office practice, Dr. Meena V. She's a pharmacovigilance officer from Nimhans and Indira Gandhi Child Health Hospital, Bangalore. And the second prize is going to next slide. The second prize is going to Dr. Deepa Manava, who's also from Bangalore. Congratulations everyone. The third webinar, which was conducted on 20th February 2025, with the topic breast cancer care from screening to survivorship. So this the first winner is Dr. Charitra Sili Shetty from MGM Hospital, Warangal. Congratulations. And the second, and she is sharing a prize with the first prize with Dr. Soni KP, who's a physician at Government Medical College, Ernakulam. And the second prize is going to Dr. Tejaswini Gondahalli. She's from Shivaganga Hospital, Belgaum, and she is sharing this prize with Dr. Afifa Sultana, who's also a physician from Saptagiri Institute of Medical Sciences, Bangalore. Coming to the fourth webinar winners, which was conducted on 25th of February 2025, Dr. Dhananjaya Reddy has won the first prize with the title of the series being Journey of Lung Mass from Diagnosis to Treatment. Dr. Dhananjaya Reddy is a gastroenterologist from Bangalore, and and the second prize is going to Dr. Gayatri Raghura, who is a public health consultant from Bangalore again. And congratulations, both of you. For the fifth webinar, which was conducted on 6th of March 2025, the first with the title ABC of CBC, and the first prize is going to Dr. Ibrahim Wajid, who is an internal medicine physician from Bangalore. And second prize is going to Dr. Vibha Prasanna Kumar, and she's from Vriksha Hospital. Next slide. So today's coming to winners of today's seminar. So today's seminar winner is the first prize is going to Dr. Soumya Prakash, who's a obstetrician and gynecologist and an IVF specialist from Bangalore. And the second prize is going to Dr. Swaroop Revana Siddhaya, who is a general physician from Bangalore again. So I would like to I would like to congratulate all the winners on winning, and the prize mini, which is for first prize, which is 12,000, and for the second prize, which is 8,000. We will be contacting you about how we'll be distributing the prize. Thank you.
Madam, we can close. Sonali?
Yeah.
We can close here, no?
Yes.